All right. We're going to go on to the next one. This is now APSA, and it is Colleen Nofi, and it's extracellular Cirp. What is it? Cirp. Exacerbates necrotizing enterocolitis. And she's from Cohen Children's Medical Center in New York.
Hi, my name is Colleen Nofi, and I'm a general surgery resident at Northwell Health. Thank you for the opportunity to present my work entitled Extracellular CIRP Exacerbates Necrotizing Enterocolitis. I am the inventor of our related patent, and I have no other conflicts of interest to report. Necrotizing enterocolitis, or NEC, is a devastating gastrointestinal disease impacting premature infants whose pathophysiology is driven by a multitude of complex pathways that are not completely understood. Further, there remains limited treatment options and an unacceptably high morbidity and mortality risk. My work focuses on a protein called cold-inducible RNA binding protein, or CIRP. Under biologic conditions, CIRP is found inside the cell where it acts as an RNA chaperone protein. However, in states of cellular stress, for example in sepsis, CIRP escapes outside the cell. Once released from the cell, CIRP becomes extracellular CIRP, or eCIRP, where it then acts as a damp by enhancing the release of cytokines and chemokines and amplifying the inflammatory cascade. Previously, we developed an eCIRP scavenging peptide named MFGE8-derived oligopeptide 3, or MOP3, that removes eCIRP from circulation to reduce inflammation. The aims of my work were to determine whether eCIRP plays a role in exacerbating NEC pathogenesis and to evaluate the therapeutic potential of our eCIRP scavenging peptide, MOP3, to protect against NEC severity and mortality. To address our aims, we utilized a murine model of NEC where pups were separated from mothers and subjected to a multitude of stressors, including hypercaloric formula gavage, enteric LPS, and hypoxic stress. We utilized wild-type and CRP knockout pups to address AIM-1, and we utilized MOP3 or vehicle treatment in wild-type pups to address AIM-2. First, we found that CRP knockout protected pups from NEC severity. Here you can see representative H&E stained intestinal sections. Upon quantification of NEC severity, we identified a reduction in NEC severity scores in CRP knockout pups, which is grossly seen by the preservation of the intestinal villi architecture, and shown in the green bar here. Our next experiments further evaluated the impact of CRP knockdown in the intestines. We demonstrated a reduction in intestinal inflammation in CRP knockout mice subjected to NEC, as assessed by mRNA levels of IL-6 and TNF-alpha in the small bowel. Here you can see that reduction represented by the green bars. To evaluate the functional impact of intestinal injury and inflammation, we utilized fluorescently labeled dextran administered enterically during our NEC model and measured systemic fluorescence as a measure of barrier dysfunction. For example, if the intestinal barrier was compromised, the fluorescent dextran would leak out of the injured intestinal wall and be detectable in the serum. Here you can see the greatest fluorescence intensity in wild-type NEC pups, indicating a leaky intestinal barrier, whereas CRP knockout pups had reduced fluorescence intensity, indicating a preserved intestinal barrier. Finally, to probe the potential clinical impact, we evaluated survival differences between our animal strains. Remarkably, in the same model under the same conditions, there was 100% survival for CRP knockout pups subjected to NEC, whereas the survival was only 65% for wild-type pups. Transitioning to our therapeutic study, we first investigated the impact of our MOP3 treatment on systemic markers in our NEC model. Here you can see that MOP3 functioned as designed, as there was a reduction in circulating eCRP levels in MOP3-treated NEC pups compared to vehicle. This reduction in eCRP also correlated with a reduction in other systemic inflammatory markers, including IL-6 and TNF-alpha. In our NEC model, treatment with MOP3 also protected against NEC severity. Here in the representative H&E stained intestinal sections, you can appreciate the preservation of the intestinal villi and associated reduction in NEC severity scores indicated by the orange bar. Furthermore, treatment with MOP3 reduced intestinal inflammation in neck as measured by mRNA levels of both IL-6 and TNF-alpha. Again, in probing intestinal barrier function, we observed high fluorescence in our vehicle-treated neck pups, indicating intestinal breakdown, whereas MOP3-treated pups had significantly reduced fluorescence intensity, indicating protection of the intestinal barrier. Finally, when we compared overall survival of murine pups subjected to the neck model, we found a significant improvement in survival up to 80% in pups treated with MOP3 compared to only 50% for vehicle-treated pups. This further supports a beneficial role of MOP3 treatment in experimental neck. Altogether, our data in neck suggests that ECRP exacerbates neck pathogenesis by increasing inflammation and intestinal injury, whereas treatment with our novel peptide MOP3 protects against neck pathogenesis by scavenging ECRP and preventing the deleterious downstream impacts. Thank you to my mentors, and I'm happy to take any questions.
Perfect. Erin.
Congratulations. This is really exciting and thorough work and a great presentation. My question for you is, what are your next steps? You've shown really impressive therapeutic benefits of MOP in mice. So how do we get this to kids?
So we, of course, want to further investigate optimal treatment with our peptide. So if we can give it different routes, if it can be given enterally. We've also been looking at other models, trying to expand and make sure results are reproducible, since we know not a single model of neck really recapitulates everything we exhibit in neonates. So right now we're already showing that MOP3 is effective in other models of ischemia reperfusion injury in the gut. So we're trying to really understand how we can maximize the beneficial impact, because you can see we have the greatest impact with CRP knockdown, whereas our MOP3 benefit is not quite the same level. So we're just trying to maximize what we can in our preclinical models right now.
Can I ask a question about your models? When you create neck, what is the timing of the MOP3 administration? Is it before the neck insult, or is it as you say, it's treatment? So is it after you create the neck?
So we actually induce 4-day neck models. So the stressors are actually continuous for 4 days, and they consist of a multitude of factors like LPS and formula gavage and hypoxia. And so we give the MOP3 treatment once per day at the beginning of the model. So the treatment is kind of ongoing with the insult of neck.
Great work. Thank you very much.
Thank you.
Thank you.
Great job.